So the study specifically on bladder preservation, what are some of the complications that come with maybe not being able to preserve the bladder, and how often does do you run into just simply not being able to preserve the bladder? Like, what's the level of quality of life impact?
So the quality of life impact as far as having a cystectomy includes sexual dysfunction, bowel and bladder dysfunction. Patients either end up with a neobladder where they have to self-catheterize, or they end up with a urostomy where they have, an external bag where they drain the urine. So there are significant also mental, emotional tolls that come with these long-term side effects. So one of the trials that was presented at ASCO, the SURE-02 trial, was looking at patients that got sacituzumab govitecan, which is an antibody drug conjugate that binds to TROP2 with pembrolizumab in the neoadjuvant setting. And so the rate for clinical complete response for the patients on this SURE-02 trial was 44%. So this is interesting, phase 2 trial looking at, can we offer patients the possibility of preserving their bladder? As it stands now, we have the option of chemotherapy with radiation for patients that choose to preserve their bladder if they meet certain metrics, such as not having too large of a tumor, not having multiple tumors, not having significant bladder dysfunction, or having hydronephrosis where the kidneys are enlarged as a result of blockage. But right now, we know that there's really good efficacy as far as neoadjuvant systemic therapy followed by cystectomy. And that was another of the big abstracts that was presented at ASCO. And the update at ASCO this year was the use of ctDNA to tell us a little bit more from a prognostic standpoint how ctDNA fits into this regimen.
You talked a little bit about the comparison of some of these regimens to what you would normally do. Are there any main areas where you're like, this is a major improvement, or areas in old regimens that you're like, okay, this was a little bit better, this is an area that we might want to preserve? And is there any room to maybe combine some of these regimens at all?
Absolutely. So we saw with the addition of durvalumab to our traditional platinum-based chemotherapy a significant improvement as far as event-free survival and overall survival. So that is our new standard of care as far as patients that are cisplatin eligible with muscle-invasive bladder cancer. Some of the data that was presented at ASCO this past weekend looked at ctDNA and found that, and that's circulating tumor DNA from a blood sample, and found that patients that had that at the beginning of before they started any of their treatment, 57% of those patients were positive. And for patients that added that immunotherapy durvalumab to the original chemotherapy that we had, 13% increase of the ctDNA clearance for patients that added the immunotherapy. So we know that immunotherapy is improving the ctDNA clearance. At this point, ctDNA is prognostic, not predictive. So it doesn't change anything as far as the duration of the regimen, but we do know that patients that don't clear their ctDNA do worse. And so in the trial, they looked at ctDNA after surgery, cystectomy as well. And we know that those patients don't do as well. So I think where the future is moving to is, to your point, combining different approaches. So there are trials looking at, for patients that are ctDNA positive, meaning we know that they're going to have a more aggressive disease, can we intensify their regimen and have a more personalized approach? For patients that are ctDNA negative, maybe those patients don't need the full duration of adjuvant treatment. And so there are trials, one called the Modern trial, which is looking at this question of escalation and de-escalation based on the ctDNA response. And then to your point too, as far as combining these approaches, there's also a trial that's going to be looking at giving chemotherapy followed by chemotherapy with radiation to look at more options for bladder preservation. And we've seen a few trials in the last few years where patients get either systemic therapy alone with or without radiation. And we're looking at the rate of clinical complete response with the option of bladder preservation. And I think that, moving into the future, hopefully we'll get to a point where patients can keep their bladders, not have to go through cystectomies, and still have long-term durable responses.